Good morning. This is Alan Braverman, and today I'm going to share with you my approach for addressing lifestyle concerns and fears for individuals and families with heritable thoracic aortic conditions. When approaching a person and family with a condition involving the thoracic aorta, it's very important to understand which disease is present and in which members. So that often involves first discussing their genetic testing or planning genetic testing for the individual and screening all family members if a gene's noted or if not for aortic imaging, and then having a very frank discussion about what is the condition, what they may know about it, and what we can do to help learn about the condition. So it's very educational. And there are so many questions that patients and families have about how to manage the condition and live life successfully. And for the individual, it can be variable depending upon which or all of these issues which may arise. And it can be very in-depth discussions. So plan a lot of time to discuss these issues, and especially symptoms of concern, quality of life issues, surgery, and many ask, how long am I going to live? So in discussing medications, many are on or ask about beta blockers and ARB drugs, which ones or both, or how do I use these? So really we just discuss the data and acknowledge there are reasonable differences in opinion about which medicine to start, or should I use both, or how much to use. And I like to emphasize how important it is when using medication like a beta blocker or an ARB to use the highest dose tolerated. Just like treating heart failure or hyperlipidemia, it's not enough just to be on a medication, but you want to use a high dose to have tissue levels in effect, like in the trials. In those who have elevated blood pressure, I discuss how important it is to get normal blood pressure, or even low blood pressure, especially after aortic dissection, and how helpful it is for you to monitor that blood pressure away from the doctor's office so I can help adjust your medications. And I like to use this example of after aortic dissection, when the blood pressure is well controlled, how less frequent recurrent aortic surgery is as compared to those who have poor blood pressure control. And this can really help motivate people to have low blood pressure and to take medications. Many are on anticoagulants because of artificial heart valves, and we discussed INR goals, the importance of following the INR, and how helpful and how it can improve your quality of life to get a home machine to monitor the INR. And to please call me if somebody initiates a new medication which can interact with your INR or your warfarin dose and affect your INR. And then I also emphasize at this visit about antibiotic prophylaxis for dental procedures if an artificial heart valve is in place, and the importance of good dental care. And I do discuss what the symptoms and signs of endocarditis are. Many are not aware of that. And when you know the symptoms to watch for, you can call me sooner, because earlier treatment may avoid surgery. Aortic imaging is critical, so we discuss it. We talk about how it may differ depending upon whether you have Marfan syndrome or really paying attention to your root or the thoracic aorta, or if you have a different condition like VEDS or LDS, where we're going to look at the whole aorta and image the cerebral circulation as well to look for aneurysm disease. And how some individuals, it's best to do a CT scan and accept radiation exposure, whereas others, an MRI, even without contrast, can be very helpful over the long term in imaging the aorta. And I like to look at the pictures and show the patients and families the images right while I'm reviewing them in the exam room, so they can see how I'm measuring things, what the dissection looks like, and they appreciate seeing those images. And I think that's helpful in the understanding. And then I can discuss how important it is to measure the aorta accurately. Patients and families really hang on every sentence when we're talking about what the aortic size is and did it change over time. And here's a sagittal image of a type B dissection measured correctly at 35 millimeters, whereas you can see if I slice it this way obliquely from anterior to posterior, I can get the same aortic measurement, same aorta now measuring 40 millimeters, mismeasured at 5 millimeters bigger. And that's a source of a lot of anxiety when individuals get aortic imaging elsewhere and get these increases in diameter. So we talk about that, we talk about the variability, and that's, I think, very helpful. Most ask about exercise and physical activity, and for some, it does impact work. and how important it is, what the guidelines are for activity and exercise, and how we have to individualize the recommendations depending upon specific aortic conditions and whether it's a mildly dilated aorta or it's after dissection, and emphasize being well, having a safe and practical approach, and do recreational athletics, and share information about what do we consider low or moderate exercise as opposed to things that we might want to avoid that carry more risk to the aorta in that individual. And then take a deep dive into what do you do for your job. And in those that it's required, modify that job, work with the employer, and advocate for your patients and support them so they can remain employed. Some individuals will have to change jobs, and some will have to file for disability based on their specific aortic or other condition. And when so, write a meaningful letter to support them and make it count so they can get the support they require and deserve. Family planning, there'll be a whole session on this. Melissa Russo is part of the GenTAC, so I'll just briefly mention how important it is to discuss contraception to prevent unplanned pregnancy, and how recommendations differ depending upon whether it's bicuspid aortopathy, maybe at lowest risk, or whether it's Marfan, Loeys-Dietz, VEDS, or Turner syndrome, which may have totally different recommendations, while some tenets still apply to all. And for most and many, pregnancy may be well tolerated, but for others may be at much higher risk. So we have to discuss that and make plans before pregnancy. And that involves many, many stakeholders that will help you get through this, and we'll all work together to come up with a plan depending upon your risk. And we discuss those risks and how imaging is important through pregnancy, and then what symptoms that are actionable, such as those of aortic dissection, and to have a plan for that if it's ever required. In the long term, we talk about surgery. Everyone's interested. And I think most important is to really emphasize that really one size does not fit all for surgical thresholds. Although we might have a line in the sand, it may not apply to all individuals. That the gene, and maybe even the mutation in that gene, as well as the size, their age, sex, body size, growth rate, and importantly, what's happened in the family of people who have the same gene. What's your phenotype? And what's the risk and benefit? And it's really a shared decision about timing for surgery. People with aortic disease worry about aortic dissection, and what symptoms should I look for? And this is the right time to talk about that. So when to take action and have concern, and what symptoms of daily life are just aches and pains and you don't have to worry, that's your aorta. And even after surgery, there is risk of distal aortic disease for many who have heritable thoracic aneurysm disease. There's a 10% incidence of descending dissection in people with Marfan syndrome after prior elective root replacement at 7 years. So it's very important. And this was emphasized again in the COMPARE trial just published, showing 9% type B or distal dissections after prior root replacement in Marfan patients. Long-term imaging and long-term clinical follow-up are critical. So we talk about this. I want to see you for the rest of your life. And that's important in aortic imaging. One can see the aorta growing over time, reaching an actionable size for surgical repair. So we have to image that. Don't take gaps in this imaging. That's important to talk about. And there are knowledge gaps, and different people have different sources of information, whether it be from the internet or social groups or different sources. And some they gather from survival curves that we've written about based on early studies of aggressive disease in different individuals. For instance, someone might come and see me with Loeys-Dietz syndrome, very worried, having type 1 Loeys-Dietz syndrome, showing me this survival curve where a mean death age at 22 years. And that's very frightening for individuals. And I can share information from more recent studies showing survival of 80% at 60 years old in a larger, more recent study where people were often identified before an aortic event occurred. So longevity and concerns are very important. After type A dissection, people are very worried about what's going to happen next. How long am I going to live? How am I going to live successfully? And I like to highlight the IRAD data that survivors after type A dissection are expected to be alive, with 90% being alive at 5 years if they're alive at hospital discharge. I call this having realistic optimism. And I think it's very important for us to share this with our patients, be realistic and be optimistic whenever possible. And I think the GenTAC Alliance has a unique possibility, and the time is right for new studies that we can now understand the clinical history of many of these conditions. Finally, quality of life is really important in all of our patients with heritable disorders of the aorta. In survivors of dissection, aortic aneurysm surgery, and other heart conditions, depression and anxiety are very common. Many don't exercise anymore or are no longer sexually active. In a PTSD screening, similar findings. 23% of people after aortic dissection followed at Cleveland Clinic 1 to 8 years after type A dissection had PTSD. And it's all the features you might imagine: unemployment, lack of exercise, sexual dysfunction that associated with mental health concerns. But those who exercised, worked, and without sexual limitations had a much different quality of life and had lower blood pressure. So these are aspects that are very ripe, again, for study, research, and for our propagation of information. There is lower health quality of life, but there are very few studies in heritable disorders. It's physical aspects affecting that, psychosocial aspects, and mental health issues. Employment being one of the most important factors in quality of life. So those who have higher scores on disease acceptance showed better scores on quality of life. So we need to emphasize awareness of this, counsel as appropriate, derive coping strategies, and improve daily life aspects of care for our patients and families with heritable disorders to impact the quality of life. And these are important areas for research and improvement. In summary, managing individuals with heritable disorders encompasses multiple aspects: surgical care, medical care, diagnostics, therapy, imaging, physical activity and family planning, and timely surgery. But the care of individuals who have heritable disorders includes recognition of important aspects of each condition that impact daily life and the quality of life. And these factors may include mental health, pain, fatigue, employment, and social aspects of the condition. Again, I believe the GenTAC Alliance is uniquely positioned to study these areas of life so important to the well-being of our community. Thank you very much for the opportunity of participating in the summit.